Ladies and gentlemen,
this episode is sponsored by Advanced Skills Company, the official agent of JPI Healthcare in Iraq. I personally use the products of JPI Healthcare in my clinic for years now, and throughout the years, these products have been amazing in terms of providing excellent image quality at the lowest radiation dose possible, and they are durable, reliable, and efficient. I recommend, if you are looking to establish your radiology practice, whether in a clinic, in a center, or in a hospital setting, to go to the JPI Healthcare website, see their products for yourself, and then call Advanced Skills Company if you are in Iraq, and these guys will provide the best possible solutions, whether in terms of hardware or software. I will leave the contact information in the video description, and don't forget to use the magic word highlights in radiology, because you will get a 10% discount on all JPI Healthcare products till the end of 2024. Hello everyone, and welcome to a new episode of Highlights in Radiology Season 2. In this episode, we are going to talk about a very important common fracture, which is scaphoid 1 fracture. Before we start, I want to remind you to subscribe, like, share, and tell your friends about us. This is Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology Season 2. Stay with me. Scaphoid bone fracture is defined as disruption of the scaphoid trabecular and or cortical bone. It is seen in both young and old population, most commonly in adolescents and young athletes. It's more common in males than females. Scaphoid bone is the largest and the most radial bone in the proximal carpal row. Its proximal surface is biconvex for articulation with the radius, and its distal surface is convex for articulation with the trapezium and the trapezoid. Medially, it articulates with the lunate and the captate bones. It is supplied by the radial artery, and here we should note that the absence of a separate proximal pole blood supply leads to propensity for delayed healing and avascular necrosis of the proximal pole. Scaphoid fractures usually happen due to dorsiflexion secondary to fall, and it constitutes 79% of carpal bones fracture. 80% of scaphoid fractures are in the waist or the middle third, and 10% are in the proximal pole, and 10% are in the distal pole osteochondral injuries. The most common presentation of scaphoid bone fracture is pain over the anatomic snuff box. Usually there is a history of contact sport, fall, or accident. Weakness will follow. Commonly the diagnosis is delayed. Later there will be limited range of motion, pain with radial deviation and flexion, and decreased grip strength. In uncomplicated fractures, there will be union in up to 95% of cases. Associated injuries include scapholunate dissociation, captate bone fracture, and triquetral bone fractures. Usually proximal pole fractures will have delayed healing, while tuberosity fractures will have good healing. Complications include non-union, malunion, degenerative changes, proximal pole avascular necrosis, distal intercalated segment instability or DISI, and humpback deformity. Treatment is either conservative or surgical. Conservative treatment includes immobilization and cast application, while surgical treatment includes internal fixation for displaced fractures with Herbert screws, which causes interfragmentary compression, will have 92% success rate using Kirshner's wires. Surgical complications include proximal third fracture avascular necrosis in 14 to 39% of cases, middle third non-union in 20% of cases, and pseudoarthrosis at the fracture site. So what radiology can offer in scaphoid bone fractures? Regarding plain radiography, scaphoid bone has 4 radiographic views, and these are 20-degree supination, 20-degree pronation, neutral posterior-anterior, and lateral views. Plain X-ray will show absence or displacement of navicular fat stripe. Non-displaced fractures will be difficult to visualize on X-ray. Like in this example, we can clearly see the non-displaced fracture line at the waist of the scaphoid bone. CT scan can identify fractures when conventional radiographs cannot, and it's most commonly used for fracture healing assessment. Like in this example, we can clearly see the non-displaced fracture line with no signs of sclerosis on both sides of the fracture line. While in this example, we can see the nice healing and union of the fracture line at the waist of the scaphoid bone. Regarding MRI on T1 weighted imaging, we will see hypointense fracture line with or without scaphoid flexion or so-called humpback deformity on sagittal images. Fracture line extending to the cortex indicate an acute fracture, while preserved cortex implies chronic fracture. Also, we should assess the displacement, which implies instability and angulation. Intercarpal instability includes dorsal intercalated segment instability or DISI, DC. A fracture is displaced and unstable if 1 or more millimeters step off or increased in the captolunate angle of more than 30 degrees. Like in this coronal T1 weighted image MRI, in which we can see a hypointense fracture line and adjacent bone marrow edema in a fracture of the middle third of the scaphoid. Another example, in this sagittal T1 weighted MR image, we can see the humpback deformity of the scaphoid bone post-internal fixation with Herbert screw. This flexion deformity is associated with the DISI pattern even in the absence of scapholunate ligament tear. Also, in this coronal T1 weighted MRI, we can see selective avulsion fracture from the scaphoid attachment of the scapholunate ligament. Another coronal T1 weighted MRI showing persistent hypointense fracture line across the proximal pole of the scaphoid despite intact radial and ulnar cortical margins in a healing scaphoid fracture. On T2 weighted MR imaging, we will see hypo to hyper intense fracture line with hyperintense bone marrow edema adjacent to or on both sides of the fracture. Less commonly, we will see diffuse scaphoid hyperintense bone marrow edema. In this coronal fat-saturated proton density image, we see hyperintense marrow edema in both proximal and distal to the scaphoid fracture site. Another example here showing bone marrow edema involving almost the entire scaphoid bone. Also, we can see hyperintense signal associated with injury to scapholunate ligament and the volar capsule. Like in this example, we can see the scaphoid bone marrow edema with widening of the scapholunate distance and increased signal intensity indicating scapholunate ligament injury. Also, it helps in the evaluation of the proximal pole hypointense signal, which indicates avascular necrosis. Also, evaluation of early scapholunate advanced collapse, also known as SLAC lesion, with control loss between distal pole scaphoid and distal radius styloid process. Like in this example, we can see the T2 hypointense signal of the proximal pole of the scaphoid bone indicating avascular necrosis. After contrast injection, we can document the viability of the proximal pole with post-contrast enhancement. Like in this case, in which we see no post-contrast enhancement of the proximal pole of the scaphoid bone after contrast injection, indicating non-viable bone. Also in this case, we can see scapholunate advanced collapse or SLAC lesion with control loss between the distal pole of the scaphoid and the radial styloid process. So what's the differential diagnosis in this case? Well, the list here includes scapholunate ligament tear, dorsal wrist ganglion, decurvial stenosic tenosynovitis, and captate bone fractures. Regarding scapholunate ligament tear, there will be dissociation between the scaphoid and the lunate bones. Scaphoid flexion relative to lunate is seen, and the scapholunate angle will measure more than 70 degrees. It is associated with dorsal intercalated segment instability, DISI, and avulsion fractures. Like we see in this case, we can see a tear of the scapholunate ligament involving the central and dorsal components of the ligament with DISI deformity. Dorsal wrist ganglion is the most common soft tissue mass in the wrist. It is located dorsal to the scapholunate interval and usually seen in patients at their 3rd to 5th decades. It presents as a painless mass with or without weakness of grip, pain, and paresthesia. Like in this example, we can clearly see the dorsal ganglion as a purely cystic lesion. Another example here showing the dorsal wrist ganglion as a purely cystic signal intensity lesion. In decurving stenosing tenosynovitis, there will be radial-sided wrist pain seen in sports like golf and occupational overuse. There will be inability to abduct the thumb, radial-sided swelling, crepitus, and pain. It affects the abductor pollicis longus and extensor pollicis brevis. Like in this case, we can see the tendons of the abductor pollicis longus and extensor pollicis brevis to be edematous and inflamed, consistent with decurving stenosing tenosynovitis. Captate bone fractures can be either isolated fractures or with periunate dislocation, called scaphocaptate syndrome. It happens due to direct trauma involving dorsiflexion mechanism. Complications include avascular necrosis and non-union. Like in this example, we can see isolated non-displaced captate bone fracture with some surrounding bone marrow edema. Also, at the CT scan, we can see isolated non-displaced captate bone fracture with no signs of healing. Well guys, this was all for today's episode. At the end, don't forget to subscribe, like, share, and tell your friends about us. If you have any comments, write them in the comment section. See you next Friday at 5 p.m. And this is Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology Season 2. Bye.